Hi everyone, my name is Jodi Lyons. I'm the CEO of Senior Sherpa and the host today of Your Need to Know. I'm joined with Dr. William Mansbach, who is the founder and creator of the BCAT Cognitive Approach. Today we'll be talking about what you need to know for cognitive issues, meaning when should I worry about myself or someone else? So Dr. Mansbach, I'm really glad you're here today.
Thank you, Jodi. Great to be here again with you.
Wonderful. So I guess the first question is, what's normal for memory loss? As an example, I was parking my car in the parking garage. I could remember that 3 months ago I parked on the 4th floor and had no idea where I parked my car in the garage this time. Is that something I need to worry about? And oh, by the way, yes, I was on my cell phone when I parked the car.
Well, you should worry about it in terms of getting to your car and getting home, but it's an indication of dementia. I don't think I would go quite that far.
Okay.
Maybe the best way to think about it is to think about, I'm going to say 3 cognitive skills that are involved in everyday living.
Okay.
And in fact, the indicators of when you should really worry could kind of fit into these 3 different categories. Brain very complex. When we think about cognitive functioning, that 6th vital sign.
Yes.
We could describe many different things, language and comprehension and judgment and so forth. But there are 3 that are particularly important that we all see every day. 3 that are used by memory specialists like myself and others to identify probable dementia, things of that sort. But 3 that are involved in everyday living, everyday tasks, and so forth. We call them at the BCAT, we call them the cognitive task manager.
Okay.
All right, so there are 3 of them. So they are attention, the ability to attend and focus. Something called contextual memory. So what does that really mean? Let's make it very simple.
Okay.
Applied memory. Memory in everyday life, memory to take your medications, memory to turn the stove off, memory to go to a doctor's appointment. Applied memory, everyday memory. The 3rd cognitive sort of category, domain, is what we call the executive functions. So this is sort of like the CEO of the brain, judgment and problem solving and things of that sort. So when someone says to me, when should I be worried? I think about it in terms of those 3 things.
Okay.
So let's start with attention. So why did you sort of forget where you parked? Was that an indication of misattention? You just weren't paying attention, you were on your cell phone? Or was it an indication of something else?
Well, exactly. And so in my defense, I was circling and circling and circling, looking for a parking space while on the phone and worried that I was going to be late for an appointment. So I came out of my appointment and had no idea. I was lucky I knew which garage I was in, let alone where in the garage I was.
So that would be an example in most circumstances of normal forgetfulness. Forgetfulness is different from memory impairment. Forgetfulness really means, and by the way, it's usually a benign situation. We all have it. What happens in forgetfulness is that we make an error in attention. That is, we're not focusing on the primary task. In this case, it is knowing where you parked. Attention is always subtractive. So if you're doing different things, like you're talking on a cell phone to somebody, you're not really paying attention to where you parked. While we think that we multitask, in reality, what happens is that we can only really pay attention to one thing at a time. We might do multiple things. Usually it's going back and forth in some ways. So
task switching, not multitasking at the same time?
Probably better to think about it in that way. So in normal aging, being forgetful means that we made an error in attention. The inability to make a new memory, maybe because you can't attend long enough, something we've talked about in this program before, like working memory and so forth. That's something very different. So if, for example, you didn't have the brain ability to remember where you were, that would be obviously an indication of a much more serious problem. So that kind of covers attention, it covers memory. This last cognitive domain in this cognitive task manager, the executive functions, well, what happens there? What happens is that a person begins to show problems in things like judgment, problem solving, reasoning, set shifting, things of that sort. So In normal aging, we tend to make more errors in attention, not necessarily an indication of dementia, but it does have implications for our ability to memorize or to remember things. The executive functions, though, should be intact in normal aging. When they are not, that could be, but doesn't guarantee that it is, that could be an indication that we have a real problem and we should then do something about it.
So it's not just memory loss that should worry us. It's memory loss that basically affects our ability to function daily. But if I hear you correctly, you're saying that the executive functioning is an even bigger clue when there's poor judgment and...
Sure.
Okay.
Think about it this way. The ability to go to a doctor's appointment. You have a doctor's appointment at 3:30. How do you get there? So that isn't just about memory. Really, it involves many different things, but it involves those executive functions, that sort of CEO of the brain in some ways. You have to figure out, well, where am I now? How do I get there? How long will it take me to get there? All that sort of thing. We tend to focus too much on memory. Very important, and of course, you know, it is the hallmark symptom of Alzheimer's disease, problems with memory. But we really should also be focusing on these executive functions. And you know what, Jodi, when you think about memory, it's important to think about it in this way. Memory, gaps in memory, deficits in memory are not uniform. They're not all the same. For example, if you can't remember somebody's name and you used to be able to do it better, that's not the same thing as forgetting to take your medication or turning the stove off. So it's not, is there a problem in memory or forgetfulness? It's about the magnitude of that in some ways.
And also, if I understand, it's also, if the person was always bad at remembering names, it doesn't matter that they're bad at remembering names now. So it's a change in something?
That's right. So when you think about the diagnosis, when we diagnose conditions like Alzheimer's disease, any kind of dementia, there must be a change, a decrease in cognitive ability and cognitive skills. So yeah, if you always had difficulty with names, you're probably going to continue to have difficulty with names. And I would even say that if you have more difficulty in names, unless it's dramatic, it probably is not in and of itself sufficient to say, oh my goodness, we have a problem here. Having said that, it is important to outline 2 or 3 possible or probable indicators, not necessarily of dementia, but that a professional perhaps should be involved. You should have a conversation, maybe with your family and with a professional, to see if indeed there is a real problem here.
So that there are triggers that warrant further exploration, not necessarily a panic moment, just we should look into this more.
That's right, and there's a whole sort of array of different things that you can do to kind of figure that out. I mean, sometimes it's the person herself that's the first one that becomes aware that maybe there's a problem. So often, and you know this in your work, it could be a family member or a caregiver or somebody who is the first to notice that, you know, there's a difference in mom. You know, somehow there's something different, not just in terms of memory, but also in terms of function. And in fact, that's often how it's first revealed, where a person functionally isn't quite doing what they were doing before, right? They're missing appointments. They're not really managing their hygiene in quite the same way. They're not doing laundry anymore. Things like that that are functionally based, not just memory, but that are everyday living skills and tasks.
So that's changes in behavior, changes in ability to function, social isolation, changes in interactions with other human beings, anything that's a change that, may, as we say, makes somebody raise a hairy eyebrow? Is that about a fair assessment?
Sure. I would only say, just to reassure people, there are lots of potential explanations for changes. The scariest one is that a person has dementia, something of that sort. But you know, there are medical conditions that can contribute. There are mood conditions. When people are depressed, for example, they don't remember things as well. They may not perform as well in everyday tasks of living. People who are taking medications, perhaps there can be side effects of medications or negative interaction effects of medications, things of that sort. So there are a number of possible explanations. The important thing is to pay attention to a change or changes in cognition, particularly in attention and memory and executive functions. And to pay attention to how that may develop in real functional terms, like laundry, like cooking, like cleaning, things of that sort.
So you had mentioned that it can be the person themselves taking an assessment, or, and I do hate the word informant, but I understand that it's a clinical term.
Sure.
That somebody else can go through some of the assessment tools to determine whether it's just strange or warrants further exploration. I know that you have a free tool, it's the SAC. Let's see if I can remember what it stands for.
Right.
Self-assessment of cognition. How's
exactly.
that? That's a good memory point, right?
Very good. Very good.
And I know that I've used your tool, and I've had many of my clients use your tool on your website. And it seems to me that that's a good way to just say, hey, I'm a little bit worried. Do I need to be, and does it warrant further exploration and explanation?
Yeah.
But I know people are afraid to do that because they're afraid it's going to come out and say, you have something really big to worry about. Can you just talk, I know you mentioned medications and some of the medical conditions, but are there other things like sleep or poor food or something like that that could also be a reason for memory loss?
Sure. So many memories begin in a part of the brain called the hippocampus and the limbic system. It's very sensitive to many different things. Some of them are health-related concerns. Some of them may be environmental or psychosocial concerns. So I think the way to think about it is all the above. In other words, it could be sleep deprivation, it could be poor appetite, it could be a co-occurring medical condition, a mood condition, things of that sort. And I liked how you talked about the idea of becoming aware of a potential problem, how important that is. And I think it's important that people understand that there are a number of different self-assessments that are out there that people can take. But really, those are potential or possible indicators. They are not diagnostic tools.
So there's really nothing to be afraid of. It's simply start to identify that which is already worrying you, or you wouldn't be worrying about finding a self-assessment tool.
Well, that's right. So a good self-assessment tool like the SAC, what makes it effective is that a person can take it who may be concerned. It can be taken as a proxy assessment too. That is, a loved one can be thinking about so-and-so. So perhaps when we come back from the break, we can talk a little bit more about how you can use tools and maybe some of the dangers of taking some of these tools a little too literally.
That would be wonderful.
Okay.
We'll be back in just a few minutes.
I helped turn my child's public school into a whole new kind of school. One with a curriculum that really motivates kids. One that has extended hours, 6 days a week, year-round. With loads of academic, cultural, and recreational activities. One that has support services like medical and dental right there. A school where parents' involvement is encouraged. Where teachers have more time to teach. And students are excited about learning. There's just one problem. My child doesn't ever want to come home. You can help turn your school into a community school for excellence. Find out how. Call 1-877-LOVE-TO-LEARN.
Welcome back. I'm Jodi Lyons, and I'm here with Dr. Mansbach. Before our break, we were talking about self-assessments for cognition. And basically, the question becomes, when should you worry, and how do you know if you need to worry? So we had started talking about the difference between a self-assessment or an informant-based versus performance-based test.
Right.
So can you tell us a little bit about the difference between the two and what we can expect when we are being tested?
So the diagnosis of dementia is often a staged process. Somebody has a subjective complaint. Subjective means that it could be the patient, it could be a family member, it could be an informant, has a specific concern. That can come from just observation, or it could really come from a self-assessment tool. You had mentioned the SAC that we use on our website. It's really just a way of giving people information to see whether or not it would make sense for them to have a conversation with their doctor. So that would be a self-assessment. So these informant-based assessment tools are either a patient, a person, taking them herself, or a loved one, a family member, somebody taking them, thinking about a specific person who is sort of the object of worry in some ways. Those are different from assessments that are actually administered by a doctor or by a healthcare professional. But I think that they work well in progression. So one of the things that would probably help with early identification of Alzheimer's disease and other dementias would be if there were more self-assessment tools that are available for people for free, so that they can have that conversation first among family and then hopefully with a doctor. Because then the doctor or the healthcare provider will be more informed, will know some specific questions that might really help determine whether or not this person should indeed be concerned about having dementia.
That makes a lot of sense. So it's basically, first step is somebody's worried. Second step is a self-assessment, either by themselves or with an informant, and then taking the results of those tests to a professional if the results of the test in the first place say you should really go to a professional.
And even if the results don't, and if a person persists in their concern or their worry, you know, it's important to think about healthcare in terms of conversations.
Right, right.
Talk to your doctor about what your concerns are. And in fact, it's part of the role of the healthcare provider to determine if there is a memory impairment or if it's a temporary one. Maybe it's caused by some other medical problem, medication, sleep, all the things that you had mentioned, or if indeed it is an indication of a true memory disorder. I know when you give talks, you often address this issue of early identification.
Yes.
Is it important or not? There are people who, on our side of the ledger, who think it's essential. Early identification is essential, and not because we have medications that will cure Alzheimer's disease, but for all the planning, all the expectations, and how do you intervene now to make life better? And if possible, how do you introduce interventions like the working memory exercises and things like that to try to slow down a progression of an illness like Alzheimer's disease? But there are other people, right, who argue because we don't have
a cure, why would they want to know?
Right.
I always say, I want people to know so we can build the safety net around them. So while we were on our break, we got an email from somebody who had a question about losing the keys. Now, we've all lost our keys, so I understand that. But she wants to know if she should be worried because she was looking for her keys, had a very hard time retracing her steps to figure out where she had them. Obviously, she needed them to get into her house. And then she found them in the freezer. And she's not the first person I've heard of finding her keys in the freezer. So should she be worried, and what should she do?
This is great. So this is not medical advice, right?
Right,
So just sort of to think about this. So we say this, when something happens, it's an event or an occurrence. When it happens the second time, it's a possible coincidence. When it happens the third time, it's a pattern. So one way to think about this is in terms of frequency. Maybe not always finding the keys in the freezer, but have there been a succession of similar kinds of things that have taken place? That's number one. Number two is to think if indeed there is a progression, or there are a number of different things that have changed in terms of function, just in the way that you described. Have a conversation. Ask other people if they have noticed any changes in your behavior in some ways. Now, sometimes friends are not always honest. Sometimes family members are not always honest. But if you don't ask the question, you don't necessarily get the feedback. third, if your concerns persist, it would be important to talk to a healthcare provider. Hopefully, the woman who emailed has a relationship with a doctor or a provider who she can have a realistic conversation. She also, if she's worried, can take the SAC or take some other assessment. There are several that are out there. And use that information to guide her as to whether or not she should have a more formal evaluation. So on the face of it, no, it doesn't mean that she has dementia.
Okay.
But these are some sort of guidelines for thinking about that particular problem.
So we've talked about the need for a change, that if somebody has always lost their keys, their losing their keys is just a continuation of their past behavior. We've talked about errors in judgment. We've talked about short-term memory or memory that affects your ability to function on a daily basis. What about mood? Is mood another warning sign that we need to check something out?
Yes, but not necessarily of dementia.
Okay.
So our moods are informative, particularly if there are changes in our mood. So the two mood features that are most common as we get older, even when we're not older, and certainly co-occur with dementia are depression, of course, and something called generalized anxiety disorder. Not everyone would recognize that, although I think most people would acknowledge that they have some familiarity either personally or with other people who have had depression. So in the early stages of Alzheimer's disease, for example, the co-occurrence of either of those or both of those is fairly high. However, most people who get depressed or who are persistently anxious about something do not have dementia, but they are reacting to a real situation. So I like to think when there are indications of depression or anxiety, it needs to be investigated and evaluated, not just because it's a sign for dementia. It may not be, but it's a sign of some particular problem. I will say this, Jodi. Depression in particular is a little tricky because it's both a clinical professional term, but it's also a lay term. You know, people talk about being depressed. What does it really mean?
So can you tell me the difference? Because when I say the word, it probably doesn't mean the same thing as when you say the word. So what's the difference?
So when I say the word, when I think about depression, it is a persistent, at least a condition that has been at a very minimum of a couple of weeks, 2 weeks, often longer than that, interferes with daily functioning. And there are a number of individual, specific symptoms that we can talk about. But before we do, and maybe instead of, it may be more useful to talk about how that may present itself differently among older adults than younger people. So, I
didn't realize there was a difference, so I think that's a good point.
Well, so one way to think about it is that if you ask an older adult who is depressed, if they feel depressed, they may or may not say that they do, but so often among older adults, an endorsement and acknowledgement of feeling depressed as a mood state doesn't really occur. What's much more likely is that there would be a change in cognitive ability, like memory, and somatic or health or bodily complaints. It's very important that if a person feels like they might be depressed, to look at a couple of questions. One question would be this: am I no longer interested in doing activities, maybe they're hobbies or whatever, that I used to be able to do? That's called anhedonia. It's related to something called apathy. It's one of the hallmark symptoms of depression among older adults. Have I lost really the interest in doing things? Not because I can't do them anymore, but because I don't want to do them anymore. So
that's if somebody was always social and now they don't want to leave their room.
Exactly.
That's a big warning sign. Okay.
So someone like that, you could ask them if they're depressed, and they may say no. It doesn't mean that they are or they aren't, but if they have that other thing, again, it doesn't mean 100% that you're depressed, but it's, of all the indications of depression, it's among the most accurate pointer or predictor of a person currently being depressed in some ways. One sort of feature about depression that people should know about is that it's really on a spectrum. It's not you're depressed or you're not. There are what are called subthreshold depressive symptoms. All that really means is that a person has some indications of depression. Maybe it's not a full-blown depressive, what's called a major depressive episode. but it's still something that should be checked out, right? If you take a self-assessment like the SAC on our website, and you score in a range that says, you know, you might really want to talk to a doctor. It could be an indication of depression as much as it could be an indication of a true memory disorder. It's important to go to the next stage, have a real evaluation.
So what I hear you saying is, if it seems wrong, it's worth looking into. If your family members think something's wrong, even if you don't, it's worth looking into. And it's not always the really big, scary answer. There could be rather benign issues or treatable conditions that cause the memory loss, cause the errors in judgment, mood, and all the rest of that. So it's not always horrible, and it is something that should be looked into. Is that a fair statement?
I think you summarized it, you distilled it very well. I'm reminded in listening to you about something that you had said in the beginning, which is really about why people hesitate to know. So when one is so concerned, so worried that they're going to have the death sentence, you know, the idea, oh, I have Alzheimer's disease. Certainly that could be a barrier to getting help, and yet indications of problems in cognition may or may not be related to a primary disorder like Alzheimer's disease. It could be related to depression or alcoholism or sleep deprivation or many other medical kinds of problems. The other thing I would say is to put a positive spin on all this. I think that individuals who have dementia, I think the task is about how to live with it and still have quality in life. Not that I'm saying that one should always be optimistic about all things, but it is important to think about it in not binary terms. And there is a life to be led. And this is one reason why early identification is really important, so you can optimize your opportunities to live a life of quality, whether you have dementia or not.
Wonderful. Thank you so much for being here, Dr. Mansbach.
My pleasure, Jodi.
And for anybody who would like to find more information, you can find Dr. Mansbach at www.thebcat.com. You can find me at www.seniorsherpa, with a hyphen between the two.com. And you can also visit the Alzheimer's Association at www.alz.org.